Hi, good afternoon. Thank you for joining us today. My name is Lori Smatenka and I'm the Executive Director of the National Consumer Voice for Quality Long-Term Care. This is the next installment of our webinar series, COVID-19, Advocating for Nursing Home Residents, sponsored by the Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition. We've been doing these webinars over the last couple of months to keep you updated on the latest information, guidance, and actions at the state and federal levels related to COVID-19, and talk about the impact on residents of long-term care facilities, share resources, and offer some recommendations for advocacy. Next slide, please, Libby. Our agenda today includes an overview of CMS's plan to send testing equipment to nursing homes. It has issued a new report about that not a new report, but it issued a new release about that about a week or so ago and has been sending testing equipment to facilities around the country. CMS has also issued an update on reporting requirements for payroll-based journal staffing information, which you know has been suspended since March. They're not collecting that data since March. And there's been a lot happening on Capitol Hill right now as Congress works to negotiate another COVID relief package. There are multiple pieces of legislation floating about, including a bill that would give immunity to long-term care providers from liability for harm experienced by residents. And after we have the presentations today, we will use the balance of time for questions and discussion. Next slide, please. Our speakers today include Richard Mollett from the Long-Term Care Community Coalition, Robin Grant from the Consumer Voice, and Sam Brooks, also from Consumer Voice. A reminder that today's webinar is being recorded. The recording and slides will be emailed out to participants in the next week or so, and will also be posted on the Consumer Voice website. You can also find the recordings and slides from the previous webinars in this series on the Consumer Voice's website, and today's slides can be downloaded from the chat box. We'll be putting a link in the box shortly. All lines will be muted throughout the webinar. Please post questions that you have for the presenters in the Q&A box on your control panel and use the chat to make comments or discuss points among yourselves. So next slide, Libby, we'll get started with presentations and I'll turn it over to Richard. Richard?
Lori, thanks very much. So I'm Richard Mollett with the Long-Term Care Community Coalition. And as Lori mentioned, I'm going to talk first about the allocation of testing equipment to nursing homes across the country, and as well as provide an update on what's going on with the nursing home reporting of direct care and other staff. Next slide, please. So a little bit of a background around the allocation of the coronavirus testing equipment. Of course, testing is a major issue for people inside of nursing homes, outside of nursing homes, and of course in other residential care settings as well. It's so important for us in order to function as a society and particularly as a community within long-term care facilities to know who is positive, who is negative, and to act accordingly in terms of cohorting, care, etc. However, as I note here, in order for it to be useful, testing needs to be three things. One, it needs to be available, and of course universally available, because if you don't have full testing, then you really are not able to provide complete information, and we have a lot of fluidity between nursing home communities and communities at large. And one issue, of course, here has been that the nursing home staff moving from one facility to another. So we really need to have a wide availability of testing, and it needs to be accurate and it needs to be timely. And if any of those three things, especially I would say the latter two, are missing, then that is a real problem in terms of the value of having testing, even if people say that it has to be done, or that which facilities have been ordered to provide testing of residents and staff, or if, as we're talking about here, that the federal government is providing testing equipment to nursing homes. I wanted to also mention, here's actually a quote from the American Academy of Family Physicians. I was looking last night when I was putting this together, and I thought this was a really good summation of what is going on with testing. So to date, no coronavirus tests have been approved by the FDA, the Food and Drug Administration. But tests are available under emergency use authorization, which means that the FDA has not thoroughly vetted these tests to grant full approval. So again, keep all these things in mind. There's limited information on the efficacy of the tests, and a low threshold of detection studies are needed to achieve the emergency use authorization status. So by that, it means that essentially there doesn't have to be a tremendous amount of confidence in the accuracy of tests for them to be used. And that again, of course, gets to my point number 2, that if it's not accurate, what, how useful is it? Next slide, please. So who, what, when, and where? So when did this start happening? As Lori mentioned, about a week or so ago, CMS announced that they were going to be rolling out, providing this testing equipment for free to nursing homes across the country. They began shipping on July 20th when the announcement came out, so that was, I guess, 11 days ago now. The equipment will be distributed over a 14-month period. Therefore, between July 20th and early October, if CMS complies with that schedule. Who's getting the tests? To be eligible, nursing homes must have a current CLIA certificate of waiver and meet certain epidemiological criteria. Notice that this is, in some of the text here is in italics. That's direct quotes from the CMS FAQ, frequently asked question document, that Lori was alluding to before, and we'll provide a link for, at the end of my section here. So CLIA means Clinical Laboratory Improvement Amendments. It's a 1988 federal law which authorized standards for certain lab tests to ensure that they're accurate, reliable, and timely. So in order for a nursing home to be eligible to receive testing equipment, they have to have a certificate of waiver for CLIA. And in addition, they must meet certain epidemiological criteria. I don't know what those are offhand, and I don't think that they named them explicitly in the FAQs. In addition, the testing equipment will be distributed based upon epidemiological hotspot data and facilities whose data indicated an elevated risk for COVID-19 transmission. And the FAQ, for those of you who are interested, spells out what that means in terms of who is considered or identified as being of an elevated risk, what facilities are identified for COVID-19 transmission. How many tests are nursing homes getting? So nursing homes are getting, again, the testing equipment, and they're getting a set of tests. These sets of tests will not be replenished according to the FAQ. So when they get these tests, any additional tests, the nursing homes will have to pay for themselves or arrange payment for. So nursing homes were categorized essentially into 5 groups based upon their needs, from small facilities that are receiving 150 tests to larger facilities that are receiving 600 tests, and for really big facilities that may be receiving 900 tests. So there's a range, and the testing is based upon, the testing amount is based upon the size of the facility. And again, facilities will be required to either purchase or arrange to receive additional tests. I didn't note it here, but there are 2 different kinds of test equipment, 2 different companies providing it, and there's information about that on the FAQ in case anyone's interested. But as far as we're concerned as consumers, that's not really an issue for us. It's an issue for who's ever going to be implementing the test. But you can see here that there is, again, a range that's being provided to hopefully meet the needs and the population of the nursing homes, at least to get them started. Next slide, please. So importantly, what type of test is being provided? The type of test that's being provided is what's called an antigen diagnostic test. And this again is from the language in the FAQ. Antigen diagnostic tests quickly detect fragments of proteins found on or within the virus by testing samples collected from the nasal cavity using swabs. So those of you who've seen it on the news or elsewhere, those are the giant swabs that they stick up someone's nose in order to get a testing sample. The bold here is my own bold, just so you know, but this again is text directly from CMS. Negative results should generally be treated as presumptive do not rule out SARS-CoV-2 infection and should not be used solely, not be used as the sole basis for treatment or patient management decisions, including infection control decisions. So let's just stop there for a second. So, these tests, from what I've heard, they're about 80% accurate, meaning that there's 20% false positives and 20% false negatives. Both of those can have, serious ramifications for the individual as well as others in his or her community, facility, etc. So there is a lot of leeway here. Not sure why they chose to go with the antigen diagnostic test. The better test, as CMS actually notes in the next sentence, is the one that does a molecular assay of the resident. I believe that is a blood test. I don't think that is a one of the tests that uses a nasal cavity. Swabs a nasal cavity, excuse me. So the molecular assay test is better. It's something that we in the Consumer Voice Center for Medicare Advocacy have been advocating for funding to provide to nursing homes in the stimulus bills that are making their way around the Hill. But right now, again, just to be clear, nursing homes are getting the antigen diagnostic test, which has it's some usefulness, but also it's unfortunately about 20% inaccuracies, and that is a significant concern for us. And then, of course, that we are pushing for the molecular assay test, excuse me. Lastly, I just want to mention negative results should be considered in the context of a patient's recent exposures, history, presence of clinical signs, etc. And as I noted in bold here, should not be used as the sole basis for treatment or patient management decisions, including infection control decisions. So I think that, in sum, we're, glad that they're getting out tests, but concerned that there is a significant level of inaccuracy in these tests, and that is going to make the testing far less useful. For further information, here is the link to the FAQ. I tried to make it as big as possible. As Lori said, the slides are available on the Consumer Voice website, and I think they're posted in the chat. So you can, if you want to look for the FAQ, you can find it there. Next slide, please. So I wanted to show quickly the two data points that they are collecting. I was really glad to see, I think last week, when they first announced the first allotment, there was only about 650 or so tests that were distributed to nursing homes across the country. In the past week, that's increased fourfold. So there's about 2,400 testing devices that have been distributed. We post this on our website. We have a dedicated coronavirus page. Our website again is nursingHome411.org. As we often do with federal data, we put it in files that are easy to use and to sort. So as you can see here, it has the provider name, address, provider city, state, and zip code and county. So all that information is really useful. So if you want to look up, see what's going on in your state, you can select provider state and just pull out the ones for your state, whether it be Florida, here we're seeing Alabama, New Jersey, etc. You can also pull out for your zip code or for your county or for your city, so you can easily see what's going on. If you're, for instance, a local or a state ombudsman program, what's going on in the, what facilities, I should say, in your communities or in your state have received the testing allocation so far. And we will endeavor to update this every week or so, assuming that CMS will be updating it as well, so you can find it on our website in a searchable format. Next slide, please. CMS also included, and we posted here, and again in a searchable format, same file, is the counties that have been identified as coronavirus hotspots by CMS. So here you can see, and I know it might be a little bit hard, but here are some of the counties in Alabama, Arizona, California, Florida. There are none in Connecticut, as I can see. So this goes down, of course, the entire country. Some states have more. You can see Florida now has a lot of hotspots. I thought that this information was actually particularly interesting. So just very quickly to go back, the nursing homes are getting this. The order of the rollout is that they're getting it if they've been identified from epidemiological data as being a hotspot, or if they are a nursing home that exists in one of these county hotspots. So this is really interesting information because it lets you know what the current hotspots are in the country, based upon data that the federal government has collected. So this again is searchable and sortable, and I think pretty useful. Next slide, please. So I'm going to move on. I'm going to quickly talk about what's going on with the PBJ nursing home staffing data. First, I wanted to give a quick background. So in 2010, under the Affordable Care Act, which many people call Obamacare, nursing homes were required to report nursing home care staff and certain other categories of non-care staff, including medical directors, pharmacists, directors of nursing, and activities staff and social work staff, and a few other categories, every single day of the year based upon auditable payroll-based data. So the actual payroll records for who the nursing home is paying to be in the facility. Before 2010, nursing homes were just providing information on their nurse staffing levels for the 2-week period prior to their annual survey. And we had long been concerned, hearing from ombudsmen and family members from across the country, that these staffing was commonly inflated by nursing homes, in the weeks around when they expected to be getting their annual survey. So that was a concern for us. And then in recent years, there have been studies that have shown that is actually true. And lo and behold, when the payroll-based journal came out, when this was implemented, they actually found that the staffing was significantly less than had been previously reported by nursing homes, because they were now reporting it based upon payroll. From our perspective, as I note here, this is probably by far the most valuable information available on nursing home compare and to the public in general on the quality of care that a nursing home is providing. Very quickly, why? Because the information that we have about nursing homes falls into 3 categories. 1 is the staffing, 2 are the inspection results, and 3 are the so-called quality measures, the MDS, minimum data set assessment, resident assessment data. The MDS data are mostly self-reported by facilities, and commonly, in our experience and observation, inflated by nursing homes to make themselves, frankly, look better. And then, of course, the citation data is based upon, or is really predicated on, the efficacy of the inspections. And unfortunately, as I think we all know, the states don't do a very good job in observing nursing homes, monitoring nursing homes, and in holding nursing homes accountable, identifying when there are failures to meet even the minimum standards of care. So as a result, I would say those inspection results don't really provide a full picture of the extent to which there may be problems in a facility. So the staffing data, 1, because staffing is so essential for resident care, and 2, because this is so clearly the most valid and accurate data now available, we think it's most useful. So very quickly, what happened was after 2010, when the Affordable Care Act passed, they required CMS, the Centers for Medicare and Medicaid Services, to implement this program for nursing homes to give CMS on a quarterly, staffing data for their facility for every day of the year. Unfortunately, CMS didn't implement that until after the Impact Act was passed in 2015. And that was, frankly, after a lot of pressure that we and the Consumer Voice and the Center for Medicare Advocacy, California Advocates for Nursing Home Reform, were also part of that we put on CMS and on the Hill to say we need to have, it's really terrible that 5 years later, the public, family members, residents, ombudsmen are still not getting this information. So, but after 2015, after the Impact Act passed, CMS implemented a program. By 2017, they had enough confidence in the accuracy of that data and of the reporting by nursing homes that they started reporting that to the public. So from 2017 on, we have had on a quarterly basis, because facilities report on a quarterly basis for every day in the quarter, we've had really good information on the staffing in nursing homes, both care staff, as I mentioned before, certain categories of non-care staff. Unfortunately, in March 2020, CMS told nursing homes that due to the pandemic, they no longer had to report, either the PBJ data or the MDS, the minimum data set resident assessment data. That's what MDS stands for. In July, we're happy to say, since I think our last call, CMS announced that they would again start requiring nursing homes to report the PBJ data starting for the second quarter of this year. So not for January, February, March, but starting April 1st, facilities will be reporting. Next slide, please. So why are these developments important? One, as I mentioned before, from our perspective, these are the most important information, the most important data available to the public of what is going on, what kind of care is being provided in a nursing home. It is also crucial to have these data for policymakers, for consumers, for researchers to know, to have these data, during this time period, during the COVID-19 pandemic, and in the months leading up to the pandemic, to know what was going on in nursing homes, what situation were nursing homes in when the pandemic started to hit and really hit, especially in the Northeast and in, of course, Washington State beginning in March and continuing to this day. So how will we know what has gone on if we don't know what the staffing was, what the MDS data were, et cetera, during this time period? Bottom line, unless there's a change in policy, we are never going to have information on nursing home staffing from January to March. CMS has utterly refused our requests to ask the facilities to provide this information, something which we are very disturbed about, that they're unwilling to do that. And we've been advocating again on the Hill to try to get some kind of law requiring them to require that of facilities, but barring that from happening, we will not see that information ever. The second quarter data, again, from April 1st on, will be collected and published as it normally would be in the fall. And then lastly, in regard to the MDS data, nursing homes still have an ongoing holiday from having to report the MDS data, such as the extent to which residents are experiencing falls, being given antipsychotic drugs, suffering from cognitive issues, et cetera. There's a lot of different types of MDS data that are collected about the residents in the facility. Some of them are more useful than others, but it's important for us, especially the ones I mentioned here, to know what is going on in the nursing home. And I just wanted to end with a couple of final thoughts. One, and because we were talking before the presenters were talking before we entered the program today, it's so disturbing, frankly, and I find it personally upsetting that we've allowed nursing homes to go on for month after month after month after month, going on 5 months now without any kind of oversight, without any visitation from ombudsmen, from their families, from the, obviously from the state agencies, the departments of health, et cetera, that nursing homes are home. And they're home to obviously a very vulnerable population. It's not a hospital ER after 9/11 or in another emergency situation. It's not a MASH unit in a war zone that we should just expect that this is going to go on under in emergency circumstances for month after month after month. And it is my feeling, and I think others as well, that is just completely unacceptable that nursing homes have been given a holiday from oversight and accountability for almost 5 months. This is not saying anything at all in regard or against the workers, many who have really been out there and doing a great job. But it's that the industry, the nursing homes themselves are taking in a lot of money at this time. They're not being held accountable at all for nursing home resident care at a time when residents are most vulnerable. And it's just incredibly disturbing to me. So I wanted to share that and hopefully plug in with others that we really need to be speaking out on these issues to our legislators on both the state and the federal level. With that, thank you. I'm going to turn it over. I am not sure, sorry if it was Robin or Sam, who's Robin. Thanks.
Okay, thank you, Richard. So I'm going to be talking about legislative news. So I would say that the big news in Congress right now is dueling COVID relief packages. And the duel is between the House and its package, which is called the HEROES Act, and the Senate and its package, which is called the HEALS Act. There is an enormous amount of information in both packages, an enormous amount of provisions. And the House bill is, I kid you not, 1,815 pages. And the Senate's package, they consist of about 8 different bills. So there's a lot out there. We've been doing our best to get at least some sense of what's in both of these packages. And what we'd like to do today is to give you a very high-level overview of some of the key points in both packages, so you can kind of compare and contrast in some of the areas that are particularly important to nursing home residents. And I just have to give you a warning, if some of the language in here sounds vague, it's because it is. Anyway, let's plunge in and start with PPE. Next slide, thank you. So personal protective equipment, everybody has become very familiar with this term. Under the HEROES Act, again, this is the package on the House side, the Defense Production Act would be used to increase the production and the delivery of PPE as well as other medical supplies. And there would be a position created called the Medical Supplies Response Coordinator. And the role of that individual would be to oversee the supply chain. On the other side, on the Senate side, the HEALS Act takes a different approach, and it focuses instead on kind of incentivizing PPE production in domestic production, I should say, by creating tax credits. And the idea here is to encourage manufacturing here in the United States to bring the PPE supply basically from China to the United States. And the second focus of the HEALS Act is to increase, replenish, refill both state and national stockpiles of medical supplies, including PPE. So the national stockpile, the government, the act would allow the federal government to partner directly with manufacturers and distributors. And then on, excuse me, and for the state stockpiles, the government would be permitted to give grants and contracts to manufacturing entities to build up those state stockpiles. So kind of, you can see right from the get-go that there are certainly different approaches here. Next slide. Okay, testing. We're hearing a lot about testing, and Richard certainly gave us a really good overview. The HEROES Act would create a national system for testing, contact tracing, surveillance, containment, mitigation. And it would also provide funding specifically for testing and contact tracing. And I think the amount is $75 billion. The HEALS Act, again, takes a different approach. It would permit the federal government to contract with public and private entities that would then assist in developing the tests and distributing them. But it would also enhance, and I'm going to quote here, what you have on the screen is the actual language from one of the bills. And it says it would enhance diagnostic testing of visitors to, personnel of, and residents of any facilities in which COVID-19 measures support more frequent testing. So I have to confess that I am not actually 100% sure what they actually mean here or how this would be done, because that's the sum total of the language. So it remains to be seen. Next slide, please. So this has to do with strike teams, which you all may have heard about before, and we've certainly discussed in previous webinars. So the HEROES Act would give $500 million to states to establish and implement strike teams. And the purpose of these teams would be to send them out to facilities within 72 hours of residents or employees being diagnosed with or suspected of having COVID-19. So the idea is to get in there as early and as quickly as possible. The act itself doesn't talk a whole bunch about what the strike teams would be doing. In the HEALS Act, this act would establish federal strike teams. So the HEROES Act is state strike teams, and the HEALS Act talks about federal strike teams. And actually, we have seen some of those teams already in a few states, and maybe you've seen them in your states. But the idea is that they are to supplement the state strike teams, not replace them. And the act actually talks a little bit about what the focus is of these federal strike teams, and it's to support clinical care, infection control, and staffing. And so actually put language in that talks about they could strike team members could provide medical exams, do some testing, and assist with infection control practices and procedures. So there's about, I believe, 150 million for these strike teams. So again, there are certainly differences between both packages. Next slide. Okay, staffing, which is certainly a huge issue. Actually, these are all huge issues. But in terms of staff, the HEROES Act supports workers in a lot of concrete ways. So what I've listed here are just some of the provisions, kind of what I thought were some of the main provisions, but there's a lot more in the Act related to workers. But first of all, the Act gives essential workers premium pay. And premium pay basically is hazard pay, and the idea that this is over and above what workers regularly get. And the Act actually spells out that it would be $13 over workers' regular pay. And there would be a fund called the HEROES Fund created for, and that's where the money for the $13 over the regular pay would come from. And that fund would be called the HEROES Fund with $200 billion in it. The second provision that I think is really critical is that the HEROES Act would provide emergency paid sick leave and emergency paid family and medical leave time to workers. We have just been hearing a lot about this as being a real concern. We've had workers who've had to choose between, because they haven't had paid sick leave, having to choose between staying home because they're sick and losing money, which they desperately need in order to pay their rent or put food on the table, or going in sick and risking making others sick. So kind of just a terrible situation to be in. So this provision here would make sure that they would get both the sick leave and the FMLA leave. And it's interesting, the Act spells out some circumstances that go beyond maybe what we would typically think of as being like sick leave. it would apply, for example, if somebody were self-isolating because they were diagnosed with it, but it would also apply if they were caring for somebody in their family who's self-isolating, if they're caring for a child whose school has closed or whose child care provider is unavailable because they have COVID. And it would also cover if somebody is caring for a family member who is somebody such as maybe an older adult or a person with disability whose place of care where they would normally go maybe during the day, whatever, is unavailable, or their healthcare provider, direct care worker is unavailable. So really tried to, I think through a number of the situations and circumstances that workers are actually experiencing right now and trying to be responsive to that. The final provision I want to highlight is that the HEROES Act requires OSHA, which is the Occupational Safety and Health Administration, to issue what's called an emergency temporary standard. There's been a lot of concern that there has not been enough action from OSHA to protect workers, and this emergency temporary standard would be required to require employers to put into in place infection control plans that would protect the workers, and those plans have to be based on what CDC is saying and what other experts are saying. So again, designed to protect workers. So that's what's in the HEROES Act, and you can see the blank boxes under the HEALS Act, and that's because there's nothing in the HEALS Act to address workers. Okay, next slide, please. So next up is reporting. Under the HEROES Act, HHS, which is the Department of Health and Human Services, would have to collect data on COVID-19 in nursing homes. The Act spells out the range of data that would be obtained. But one of the pieces of data that struck me was that it would be required to collect the number of clinical and non-clinical staff providing direct patient care at each facility, which would be very helpful information. And in addition, there's been a growing concern about racial and ethnic disparities in terms of who's being affected by COVID. So HHS would also have to report demographic data for suspected and confirmed cases of COVID. And then that data would be required to be posted on Nursing Home Compare. On the other side, on the Senate side, in the HEALS Act, the reporting would be limited to giving the governor of each state a list of facilities in which the reported cases of COVID increased during the previous week. So it would be a weekly report that would indicate where there's been increases. Okay, next slide. So both bills have requirements that relate to sort of infection control, support, and training. So the HEROES Act actually mandates CMS to contract with at least one QIO, Quality Improvement Organization, to provide infection control support to nursing homes. And the Act also says that that support has to include developing and disseminating protocols as well as training materials. On the other hand, the HEALS Act calls for the development of online training courses, and it's interesting. Those would be developed for facilities, obviously, but survey agencies, the long-term care ombudsman, and other individuals, so not just for nursing homes. It calls for developing training materials, again, for facilities, but also, and specifically calls out the long-term care ombudsman and other individuals. And then in addition, it calls for the creation of training courses on best practices in infection control and prevention. And it too, although it doesn't say it would be the QIO, but the HEALS Act also calls for providing support to facilities, particularly in areas that are determined to really need assistance because of the presence of COVID-19 infections. So that's the HEALS Act aspect of infection control support and training. Interestingly, the HEALS Act actually authorizes the HHS secretary in consultation with the Elder Justice Coordinating Council. And I had not seen that or really thought about the Elder Justice Coordinating Council doing this kind of work. So that was an interesting aspect of the bill. Next slide, please. And finally, I just want to mention a couple of provisions in the HEROES Act that are not in the HEALS Act. So rather than putting up boxes with nothing on the side of the HEALS Act, I just thought I would cover it briefly at the end. So the HEROES Act calls for televisitation. So it would require facilities to have a way for residents to do televisitation with family and friends when they can't do in-person visits. And it would also establish actually certain criteria that a facility or a unit that is going to put itself out there as being COVID only would have to meet in order to be designated as a COVID-only facility or unit. This has been an issue that advocates like Consumer Voice and Center for Medicare Advocacy and Long-Term Care Community Coalition have all been really concerned about, because we've been hearing that facilities, really poor performing facilities, 1-star facility, 2, sometimes even special focus facilities have been have decided that they're going to be COVID only, when their track record certainly indicates that they're certainly not in a position to be providing quality care to anyone, let alone someone with COVID. So the Act actually spells out what that criteria would be, and it also says that if the facility gets such a designation, that it has to notify residents of the designation and whether they'll be moved if they're not eligible for the facility. So if the facility is going to be COVID only and the resident doesn't have COVID, that's when that notification would apply, and it would be, I believe, like within 72 hours notification, because as I'm sure you all know, right now the notification when somebody is being moved related to COVID cohorting or grouping has been waived. So there's essentially it's basically as soon as practical, which often ends up being not at all. So anyway, that's there are also some other differences between the two bills that we won't go into now, but I will say that there's a major part of the HEALS Act that is not in the HEROES Act. And that's a bill that grants nursing homes immunity from liability for negligent care. And that's the segue for Sam, who's going to talk to you about that.
Thank you, Robin. And as Robin just indicated, I'm going to talk to everyone today about this newly introduced Senate bill called the Safe to Work Act, or Senate Bill numbers, excuse me, 4317. This bill was introduced this week on Monday by Senators Cornyn and McConnell, and it addresses what Senator McConnell has been talking about really since any discussion of additional COVID emergency relief and that's immunity. He said this is a red line issue and that any additional relief would have to include immunity for not only nursing homes, for a broad swath of businesses. And that's what the Safe to Work Act is. It is a broad, far-reaching bill that bars a variety of court claims during the pandemic. And what it is designed to do is shield employers, businesses, schools, hospitals, doctors, nursing homes, and more from a variety of liability that could arise during the pandemic. I won't go into every particular of the proposed bill, but just to say that this bill takes away the rights of most employees, takes away the rights of most individuals that enter into businesses and potentially do business with businesses. And for our purposes, it takes away a lot of the rights and puts really all nursing home residents at risk of harm. Nursing home residents and other individuals who are seeking help from doctors or at hospitals. So it's a very broad-reaching bill, but for today, what we will talk about is how it affects nursing home residents. And don't take it as it is. Safe to Work Act is not about being safe going to work. In fact, it is probably the opposite. It is not about making workers safe, and it certainly isn't about making nursing home residents safe either. And you'll see why as we go through the slides. Next slide, please. So how does the Safe to Work Act affect nursing homes? What are the provisions in it? And it's a very sort of fragmented bill, and it has lots of different provisions, and frankly, it's very confusing. And I think it has caused a lot of concern and about what we do know, and a lot of concern about what we don't know from the bill. What it says is that if a lawsuit is brought against a facility during a 5-year period, and that is dated back to December of 2019, and it goes through 2024. If a lawsuit is brought against a facility by a resident, it will be able to be heard in federal court. So it takes it out, it allows defendants to remove all cases to federal court, and it creates exclusive jurisdiction there and an exclusive cause of action around any cases that stem during this period. It also reduces the statute of limitations on claims to 1 year. What it does is bars all claims of negligence against facilities for 5 years. And it is not limited to claims of harm because of COVID. All harm, including deaths, will likely be barred. And it creates impossibly high evidentiary standards. But what I want to highlight in these last 3 points here is that negligence is the idea that individuals, businesses, in this case nursing homes, who act unreasonably and provide care that is unreasonable and departs from what normal actors would provide, what normal nursing homes and would have long been accepted standards of care would provide, and that harms a resident, that is negligence. And currently, I would suspect about 9 out of 10, if not more, cases brought against facilities are about negligence. So what it says is all of those claims will be barred. And not only will claims be barred that are about negligence, but it's not just related to COVID. It's not just about a facility's potential negligence infecting residents with COVID. And we know that unfortunately has been the case. And a lot of this pandemic is that it's really about facilities' failure to properly protect residents that has caused so much of the damage. But this is any negligence. All harm really under a negligence theory will be barred. And that means that some facilities who've had no cases of COVID, if they're able to tie their failure to provide appropriate care to a resident and that resident's harmed, if they can say they were responding to some sort of COVID. And who hasn't responded to COVID in the past 4 months, 5 months? What aspect of American life hasn't been touched by COVID? And so it's really a negligible standard. And it says that the facility can tie it into that, that claim will be barred. So that means neglect, failure to provide nutrition, failure to reposition residents who are bedridden. Every possible thing that you can probably think of will be barred. And it will be barred for 5 years. What it does is it creates impossibly high evidentiary standards. What the bill says is you can't recover for negligence, but you can recover for gross negligence or willful misconduct. And those are defined in the bill. And they're defined in such a way, was really, it has to amount to criminal behavior. If you'd have to show that they acted with intent and a certain state of mind, and that was what caused the harm. And what this is going to do is just really prevent all claims from being brought. Next slide, please. So as I had mentioned before, nursing homes will only need to show that the care that harmed the resident was impacted because of the coronavirus. And so to prevail, and as I indicated before, I mean, what hasn't been impacted by the coronavirus and COVID? And to prevail, they will have to meet this very, very high standard. And what is also most egregious about this law, I mean, it's all egregious, don't get me wrong, but a lot of immunity, how the industry has pushed immunity, and trust me, they've been pushing it since early April, since really even before it became clear how devastating COVID was going to be upon nursing home residents. They've been pursuing it, pursuing immunity. They have cited lack of PPE and staff and other necessary supplies caused by COVID. However, this law doesn't differentiate between facilities who made efforts to get PPE or made efforts to get appropriate staff. It bars all claims. So the facility that went out and tried to get PPE but were prevented by COVID, by shortages, by national shortages, or by something out of their control, will be treated just the same as a facility that did not make those efforts. This is just reprehensible. And it caps damages. And what that means is it only provides for compensatory damages. And I'll get into this a little more. So it only allows for initially for compensatory damages, which really is based upon someone's age, whether they're working. And so for nursing home residents who are often impoverished or on Medicaid or Medicare at the end stages of their life, there will be zero compensatory damages. And it says in order to get punitive damages, that, you know, to have damages that punishes the facility, you have to meet this heightened standard of willful conduct. You have to show that they meant to do it. And it's a very high standard. But not only that, punitive damages are capped at the amount of compensatory damages. So what that means is for residents who were harmed or killed by facilities negligence, nothing will happen to them. There will be no awards for nursing home residents. So this bill essentially values nursing home residents as life is worth $0. Next slide, please. And why is this bad? I mean, I don't have to explain to you why this is bad, but it has repercussions far beyond just lawsuits. It's not just about, I mean, most family members don't want to have to bring lawsuits. What they want to make sure is that their loved ones are safe. But what this bill does is it removes one of the last remaining protections for residents. As you all know, family members, residents' best advocates, haven't seen their loved ones for months, or over 4 months. Nursing home ombudsmen have not been able to enter facilities. Licensing agencies who go in and investigate complaints and conduct surveys have not been in. Really, there's nothing there to protect residents. And this is likely the last protection. So in the middle of this pandemic, where people are suffering the most, the Senate Republicans have decided to remove this one last protection. And not only does it do that, it creates new standards of care. It says you no longer have to act reasonably. It says facilities that don't act reasonably will not face repercussions. So what it does is it upturns and realigns every idea that we have always considered that was proper and appropriate care for residents. And it endorses that type of care, the provision of that type of care to nursing home residents. What this will do, it will result in further harm and devastation to residents and their families. Again, our concern is what's going to happen to current residents and future residents. This is for 5 years. This is going to leave nursing home residents unprotected for 5 years. And it makes workers less safe. Hundreds and hundreds of workers have died. This act cynically and knowingly capitalizes upon their sacrifice by saying it's about making workers more safe. It's not true. When you remove standards of, when you remove the incentive to comply with regulations, the conditions and facilities deteriorate and workers are more likely to be harmed. Further, the bill in other sections removes protections under OSHA, the Civil Rights Act, the Americans with Disabilities Act, and various other laws designed to protect workers. It removes those protections. So this is not about workers. Next slide. What can you do? And this is extremely important. This could be decided this weekend. They are, Democrats who oppose immunity have been very good about this and have said that they oppose immunity particularly they oppose this act, but they oppose immunity for businesses and nursing homes. However, we're going into negotiations and it could happen this weekend. So what we need for folks to do, and what we are doing, is we're reaching out to Congress to tell them that we oppose the Safe to Work Act and immunity for nursing homes. We need to tell them that they should not be removing these protections. They should not be taking steps to harm more residents during a pandemic that is not over, and cases are rising in the South, in Texas and Florida, and potentially getting worse. The numbers here, you can call the U.S. Capitol switchboard and they will transfer you to your senators and your representatives. We also put links here. You can go here to email your representative and your senator. You don't have to write a tome. All you have to do is, we oppose the Safe to Work Act and immunity for nursing homes. This act will put residents at risk of further harm. And they need to hear from you this weekend, today, and you need to get the word out that this is not going to be accepted. Next slide. Okay, I'll turn it back over to Lori.
Lori,
Thank you. Yes.
This is Robin. I just wondered, I wanted to just add before we moved on to what Sam said. We are going to be sending out an action alert by the end of the day. So that is an easy way to send a quick message to your members of Congress. It will have the message already in there. All you have to do is click. So certainly you can call and do those other things as well, but for those of you for whom maybe this is just the easiest, we'll be getting that out just as soon as possible today.
Thanks, Robin, and thank you to Richard, Sam, and Robin for their the information that they shared, critically important information. And We know that a lot's been happening over the last not only months, but a few weeks, but felt that you really needed to know about these things today, particularly related to the legislation and the immunity, because those things are being negotiated right now. And final decisions are being made, as Sam and Robin said, as soon as this weekend or early next week. So with respect to the immunity provisions, it is very critical that you contact your legislators right away and let them know that these provisions are harmful. You can look at the information on the slide, or as Robin said, the action alert. We're at the top of the hour, so I think we're going to have to close for today. I know that a lot of questions have come in, and a lot of you have been asking even about the visitation issues. We are still very concerned about that and have been advocating very strongly with CMS and with Congress and at the state level around the visitation issue. We'll do more programming on that in the coming weeks, and we'll be sharing additional information along with our partner groups. Keep watching our websites from all of the organizations that are sponsoring these webinars for more information about COVID issues, additional resources that families can use, and additional programming that's going to be offered. Next slide, Libby. Please also continue sharing your stories with us. There's a provision on the Consumer Voice website on our COVID page about sharing your story. They're critically, critically important as we talk to members of Congress, as we talk to CMS. If you're willing to talk to the media, there's a box on there that you can check for that, so that as we get requests from the media to talk to family members or other advocates, we can direct them to you. But it's critically important that we hear the on-the-ground stories as well about what's happening. Next slide, please, Libby. And please go to the next one. So there's our contact information from the different organizations, the websites, the email addresses of all of us who've been working very closely on this issue. Stay tuned for additional programming that's going to be coming up in the future. And thanks so much for all the work that you're doing on behalf of residents, all the advocacy that you're doing on behalf of residents and your family members. And with that, we're going to close for today. So thank you. Have a good weekend.